Well, good afternoon, everyone, and welcome. I hope that you have found a cool place to be sitting today and maybe near an air conditioner or a fan. We're really glad to have you with us today. My name is Kate Cimino, and I serve as Executive Director of the Citizens League. Citizens League is a nonpartisan, or we like to say multi-partisan, nonprofit organization. It's based in St. Paul, and we work statewide. And we empower people to engage in civic life and in public policy on issues that are important to them and important to our state. We are particularly interested in how certain policy issues may show up a little bit differently in rural areas and small towns versus in the metro, and even within the metro, sometimes show up differently depending on a lot of dynamics. And we started talking about this idea over the last year to have a series where we take a policy issue or a public policy challenge and unpack it a little bit and look at how it's showing up maybe differently in different parts of the state. We know there are commonalities and there are common threads, common challenges and common opportunities, but we also know that there are times when the solutions may look a little bit different and the problems may look a little bit different too, depending on where you are in the state. And we wanted to set aside some time to dig in on that and help ourselves and help you and help a conversation in our communities understand those dynamics a little bit better. So we at the Citizens League are really pleased to be partnering with the Center for Rural Policy and Development and the great team there to be putting on this series. This event today is the third in the series. We're going to take a summer break so you can enjoy your Minnesota summer, and we'll be back then in the fall with more events in the series on different policy areas. So if you have ideas of issues that you think have an interesting dynamic depending on where you're sitting in the state, let us know. Feel free to put that in the chat, drop us a line. We've done events on childcare and on workforce, and today we're talking about healthcare access. So help us brainstorm what ideas might be interesting to look into next. The research team at Center for Rural Policy and Development do awesome work, and I'm not like setting them up for suggestions necessarily for their next research project, but you never know, it could happen. So today, I'm going to momentarily turn it over to Julie from the center, and she will introduce the center's work and our panelists in our event today. And then our moderator, Christina Palladino, is going to be hopping in to moderate the conversation among our panelists. And we are really fortunate to have Christina with us for this series. She's from at Park Street Public currently, but comes from a long career in broadcast journalism and multi-award-winning broadcast journalist, and has brought just a really great eye and a great lens to these conversations we've been having. So I see you, Christina. Thanks for being here and for being part of this series with us. And thank you for attending. It is always nice to be able to gather an audience and talk through some issues together, and hope that you leave today with maybe a few more questions, a few insights, and curiosity for the next step, whatever that may be for you professionally or personally, learning or applying what we chat about today. So with that, I will turn it over to Julie Tesh.
Thanks, Kate. Great to see all of you today on the webinar. Thank you for being on today. I know it is a beautiful day in Minnesota, and so I thank you for taking time out of your busy schedules to be here with us today. Like Kate said, my name is Julie Tesh, and I'm the president and CEO of the Center for Rural Policy and Development. And if you've heard of us before, that's awesome. If you have not heard of us before, just to give you a quick background, we're a nonprofit research organization, and we focus on rural issues. And all three of us that are on staff there, it's myself and I have two researchers. We are very passionate about rural, but we also understand that issues in rural may look similar, may look different, so there's nuances with the metro and with urban, or metro and rural. And so when we started talking about this series a while back with Citizens League, we decided it's like, what a great opportunity to go over some policy, go over some ideas, but to learn from each other and learn from those diversity of places. You know, what happens in northern Minnesota for healthcare may look very different than where I'm at here in southern Minnesota. And what happens in St. Paul may look different than what's in Maple Grove. And so this is the third meeting that we've had, conversation that we've had, like Kate said, and it's really gotten people to start thinking of some ideas. And so my hope in the future is that we can continue these discussions, but maybe even go more in depth, because right now we're kind of at like that 30,000 foot level. We're skimming the surface, and you're going to hear from some wonderful panelists today for that discussion. But it'll really get you thinking on what we can do policy wise for the whole state of Minnesota and where that nuance is. So if you're interested, check out our research at ruralmn.org. You can sign up for our newsletter and everything, but we will be releasing our research agenda this coming month. And so Kate, you just never know what will be in the research agenda. So, and also if you have any questions throughout this, please put it in the chat, and Marnie from the center will be moderating that. So please feel free to put those ideas for topics in the fall, but also questions you may have. I am going to turn it over to Kelly Ash. And Kelly is our research associate here at the center, and he is based in New London, Minnesota. And he has done yeoman's work on rural healthcare research. And the report that we put out a year and a half ago on healthcare access in rural areas really was well received, but really got people talking. And so this is just the perfect place where we can intersect with those in urban areas, but also thinking about diversity, equity, and inclusion as well. And where do all of those things fit in? So Kelly, I'm going to turn it over to you, and thank you so much.
Thanks, everybody. Yeah, my name is Kelly Ash from New London, Minnesota. I'm going to be talking a little bit about some of the kind of framework that healthcare currently exists in, particularly regulatory and policy-wise, and how this kind of push through regulations is really making some of these changes happening that a lot of people are probably experiencing or witnessing in their regions, particularly around some of the mergers and consolidations and acquisitions that are occurring in the healthcare industry. And there are a lot of pieces to healthcare, as you all know. It's a very complex issue. What I'm going to be presenting now just kind of talks a little bit more generally about what we would consider more traditional type healthcare, which is access to like clinics, hospitals, and those types of services. But I should say what I'm going to talk about now definitely relates to other things such as EMS and other types of specialty type healthcare that exists as well. And all of those are being impacted by some of these kinds of policy pushes that we're seeing at the state and federal level. So let's talk a little bit about that. So one is, let's talk about a shift in payment philosophy. And I would say over particularly in the past 10 years, we've been really seeing this shift. And it coincides with research that was done in the 70s and 80s and even early 90s, where a lot of healthcare research came out saying, hey, we're paying a lot for healthcare and our outcomes aren't particularly great. We need to fix this. We need to have a different set of policies that push different types of model in providing healthcare. And you probably have heard this before, but a lot of modern healthcare policy kind of is centered around this, what they call triple aim. So it's aiming to improve the experience of care. And this is really around this idea of being a patient-focused, patient-centered relationship where a patient can go through something and it's this very seamless experience from different types of healthcare services without it being so siloed. The second piece is improving the health of populations. And the third is reducing per capita costs of healthcare. So essentially we want better outcomes and we want it to cost less. And we want the experience to be awesome. Those are kind of like the triple aim of modern healthcare policy and where this push is coming from. Another way to kind of look at this is really like changing the relationship and the experience that a patient might have. So here on the left, you can see if this is one patient, it was a very siloed type idea. So vaccines was something different. You might have a relationship with your physician, but that was a different relationship than you might have had with the hospital, which was a very different relationship you might have had with the pharmacy. And none of these folks were maybe talking in a cohesive way to each other about you as a patient, right? It was just kind of very sectioned off. And even I think some of the things that were occurring in the community, such as exercising, wasn't really a healthcare issue. It was more like exercise. You should exercise, but it wasn't integrated into the healthcare experience. On the right here is kind of more where the policy is trying to drive and push the entire healthcare industry, which is this kind of patient-focused, patient-centered, where everybody is communicating about you. They're communicating with each other about you. And that's primary care, specialty care, pharmacy, even community initiatives to make people healthier, to try and get ahead of anything severe health-wise that you might experience. How can we as a community be healthier people so those things don't happen, thus driving down costs and making healthcare a better experience? So this also trickles down into a shift in how we're paying for healthcare, or I should say how the payers are paying for healthcare, because sometimes we are inadvertently paying for healthcare, but maybe not directly through insurance companies and government programs. The kind of old style of paying for healthcare services was more of this kind of fee for service. So if you went to the doctor, you paid for that doctor visit. If you went to a specialty care, the payer had to pay for that visit, and you had to pay separately for an x-ray, and everything that you did had its own kind of bill. And that's how much was charged to the payer, and the payer paid it or negotiated, or they kind of figured that out. What we're starting to shift, and it's really hitting home, I think, over the past 5 to 10 years, is there's different names for it. And here I'm calling it value-based care. But essentially, providers are reimbursed based on the quality and efficiency of the care they provide. It's essentially incentivizing costs and better outcomes. To kind of explain how that happens, I put together just this chart. And here's 50 patients that had procedure A done on them. And that cost of that procedure to the hospital was either between $200 or $1,000, just depending on the patient for the exact same procedure, because not every procedure is different. This is all hypothetical, but it's to help explain what's happening here. Instead of the payer paying $1,000 for this patient, $750 for this patient, and $200 for this patient, the payer is essentially telling our healthcare providers, it should cost on average $558. That's all you're getting. Even if the patient that we insure, it cost you $1,000, we're still paying you $558.64. That's just the way of the game. Figure it out. So for a hospital, it really incentivizes them to figure out, how do we get more of these patients that cost more down here? Because then they make a little bit more profit, or it's a little bit more sustainable. That's kind of, it's much more nuanced, and there's a lot going into this, but that's kind of the grand scheme of where things are kind of heading when we look at healthcare policy. Another idea, theoretical difference in payments, is essentially saying, instead of paying for individual patient care, we're paying for a group. So everybody that has, let's say, some sort of heart procedure done, we're paying the same for all those patients that had that procedure done. So essentially kind of just reinforcing that idea of like, we're getting away from this like paying for each individual and more towards what something should cost. And how do we incentivize people to be healthier, or the hospitals to be more efficient, while also providing better care so they don't have to see that patient again. Here's a couple of examples of things you might have heard: global payments to providers. So there's been some testing across the country from different states, either Medicare or Medicaid. They'll just essentially say, hey, for all of our patients in, let's say, the state of Massachusetts that are under Medicare, we're giving you this many millions of dollars. Doesn't matter what service they're going for. Doesn't matter what happens to them. That's the budget you get. Figure out how you're going to take care of those patients in that population. Some will come in under, some will be over, but you need to figure that out. Again, it's to kind of incentivize and push hospital providers or healthcare providers to try and figure out ways to make people healthier. Episode of care payments is kind of the same thing. I've been talking a lot about that. It's just, for the same type of procedure, this is what we're paying. We're paying for the episode of care, not exactly the cost of taking care of that patient. And a lot of this is leading to what we call team-based holistic approach to care. So you're seeing a lot more hospitals, and I'm sure anybody that's gone recently to see their family physician or doctor, you're starting to notice that there's a much more integrated approach to you. For example, I just went and I had high triglycerides. And so my physician had a conversation with their nutritionist or dietitian, and I got to meet with them, and they had a conversation. And it was very different from 10 years ago, when the doctor would have probably just said, you got high triglycerides, we're going to put you on these meds, figure it out. Or you can go to the dietitian, here's their card, go talk to them, hopefully it'll help. So you're starting to see a lot of changes in that regard. So what are healthcare providers doing? What kind of strategies are they implementing to adapt to this whole new situation? The first big one is risk sharing. So essentially, they need to get used to this idea that they have some people that do really well and some people that don't do really well. They're going to get paid the same for all types of things. How do we spread that risk across the population so it kind of evens out? And that population needs to be quite a high number for those numbers to work out and for it to be financially feasible. Another one is upgrading technology. I don't think there's been more evidence of how important upgrading technology, particularly medical records, has been without going through COVID-19. I think seeing how well that the healthcare providers were able to identify at-risk patients of theirs and say, hey, we want you, your priority for the COVID-19 vaccine, we're going to get you in, is a clear sign that going digital, upgrading our technology, and being able to identify these things is really, really important as we move forward. And it's not just about tracking, but it's also doing the analysis to try and figure out like which of our patients are at risk of costing us a lot of money and how can we help them. So obviously it's financially better for us, but also better for the person living. Develop enhanced coordinated care. So again, that kind of holistic approach. How are the different aspects of care coming together and talking about you as a patient and your care in a holistic way? Utilizing efficiencies. This can be anything from purchasing power. So if you have a large patient pool, you can buy supplies in bulk in larger numbers, thus getting better efficiency and a better price for those supplies. And then the last piece is negotiating higher reimbursements. So still, with healthcare mergers and acquisitions and systems becoming larger, they're getting more and more of the patient pool. They can then theoretically negotiate slightly higher reimbursements from insurance companies to help pay for some of their services. I say that though with a little skepticism too, because Medicare and Medicaid set rates for a lot of procedures, and the insurance companies will say, hey, Medicare and Medicaid, you just set the rate for that. So that's what we're going with, take it or leave it. That's what we're going with. So sometimes in a way, the government can be kind of the setters in price as well. So how does this all impact rural hospitals in the new reality? And rural hospitals, I should say rural healthcare, clinics, physician groups, even rural EMS. And this is how it looks. And I thought this quote from a doctor in central Minnesota put it pretty well, because when we first started hearing about this issue and we talked to people in rural Minnesota, a lot of them had this idea that it was the big, nasty, healthcare system coming in and gobbling up their small doctor clinics and their small hospitals and, what in the world is going on. But what we found out just through interviews and looking at research is that actually a lot of the smaller clinics and hospitals had a desire to be acquired. So as one doctor in central Minnesota explained it, who their small physician group merged with a larger system, he says, when we were looking at our future projections, we knew we couldn't make it on our own as a smallish physicians group. We knew we needed to merge with a larger system to help our financial outlook. And that's really kind of the name of the game, because a lot of these folks have a small patient pool. And when you have a small patient pool, it does not mean you can do risk sharing very well. You have less capital to upgrade your technology and stay on the cutting edge. It means it's harder to utilize efficiencies, and you don't have the leverage to go negotiate higher reimbursements if that's possible. It's just a system right now that doesn't play well with small pools of patients. The other big piece that you hear a lot about, and this isn't just rural areas, but I think healthcare in general, is the struggle to attract specialists and workforce. And as you saw, there's this big push and a lot of incentives to develop enhanced coordinated care in healthcare right now. But if you don't have access to the specialty care that's needed to develop that coordinated care, it can be a lot more challenging. And so in smaller rural hospitals and clinics, they don't have access to that specialty care. And so merging with a larger system that does can make a lot of sense, and being able to provide a larger swath of services and coordinate with some of the specialty folks in those fields. And there's just the flat out reality that rural healthcare costs more. We're older, so that means one, patients cost more because they require more services as we get older, but also means a larger percentage of their patient pool is on Medicare. And although that's great for the patient, Medicare is a very important piece. They don't typically have great reimbursements for their patients. They're typically, a lot of hospitals and clinics will say, we don't make any money. It typically costs more. Maybe we break even, but barely for serving patients that are on Medicare. And that's just an unfortunate piece of this policy situation. They're also sicker typically in rural areas, just generally a little bit unhealthier, and poorer. And so poorer means, one, that they might be on a government program that doesn't reimburse as well as maybe an insurance company with somebody that's privately insured. But it also means a lot more folks might have, it might just be flat out unable to pay for their services, and they're uninsured. And typically what happens is the clinic or the hospital ends up gobbling up that debt. They could go try and get that money, but it's probably never going to come. So they have more bad debt on their books than typically metropolitan healthcare providers that provide metropolitan populations. And this chart here is margins for each hospital. So this is the percent of revenue above net even. So essentially what this is saying, this is hospitals, all the hospitals located entirely rural, town-rural mix, urban-town-rural mix, and entirely urban. The average margin for our entirely rural hospitals was 0.1%. And actually 69% of the hospitals were below what we consider a healthy margin, profit margin, which is 4%. That's this black line here. And you can see there's very few hospitals that are above that black line. And the margins continue to increase a little bit more as we become more metropolitan. Obviously not great yet, but it does kind of indicate and show us that if you're operating a healthcare provider, if you're a healthcare provider largely serving rural patients, you're going to have a tougher time making money off of it. So large is the name of a game. Larger healthcare systems will come in because they're always looking for more patients. Not just for financial, but they could think it's a good thing to provide in a rural area. They want to serve, they want to do their work, and so it makes a lot of sense for them to come in and maybe purchase a smaller hospital or physicians group, and it also makes sense for the smaller hospital to do that as well. And it again opens up all these other possibilities of risk sharing, technology upgrades, and access to specialty care and whatnot. So that's kind of what's happening. The impacts due to COVID-19, because I figured this was going to come up. It was bad at first because we had to shut down. We weren't allowing healthcare providers to take in any new patients or patients to do kind of typical non-emergency services. And a lot of those services are the ones in which hospitals and clinics make money on. So they have to have all the staff and all this capital going on while not getting any, being able to provide any services to make revenue. And so it was tough there for a while. I think a lot of hospitals and clinics will say that the federal government stepping in and the state government grants really, really helped. And I think got a lot of folks by. I'd be curious to see, I haven't seen any of the hospital annual reports yet that kind of start looking at those financial numbers. I'd be curious to see what those look like. But I think the policy situation and response to the whole situation was really, really good. And I think it was very appreciated by healthcare providers in general. So for a lot of hospitals and clinics, we have a few options for cost cutting. One is just flat out eliminating services, and that might be done by smaller clinics and hospitals that just either don't have the workforce to provide it, don't have the patient pool to provide it. There might be it costs too much. They're not making any money. It's a net loss for providing that service, so they might eliminate it. Relocating services, so that's kind of what we can call a consolidation of services. So if you are part of a larger system and you're offering you have duplication of services in different spots, it might make sense to eliminate it in a spot where it's not being utilized as much and just merge it with one that is being utilized more to get more efficiency. But that then again will impact people's travel times to reach that service. And then there's also just flat out eliminating staff. And that's always a little concerning, particularly in rural areas. I don't know how many people know this, but healthcare is almost always number one or number two in almost every county of the state as far as employment. It's a huge industry, and they're generally pretty good paying jobs. And so the elimination of staff is always a little concerning for rural areas because it's considered, good employment. We did take a look at what can access look like today. And this is a little bit hard because it's not tracked as well as you think it would be. MDH, the Minnesota Department of Health, does a really good job with the data we have access to. But again, it's kind of hard to say. And so this is what we've gathered. This is from the Minnesota Department of Health. They kind of have a rural health book, I think it's called. They do a great job at taking a look at all of this stuff. And this just saw rural hospitals saw service declines due to hospital closures, consolidation, or service loss over the past decade. So this is 2009 to 2018. And you can see inpatient surgery went down by 10, almost 11%, outpatient surgery, 8%, a little bit of increase in outpatient psychiatric, detox services went down 30%. So you can kind of see lots of negative signs here. So it's pretty good indicator that, yeah, there's some consolidation happening. We're losing some services. And we don't quite know what that means as far as folks having to travel. Another one that a lot of folks talk about is obstetrics. So being able to provide birth services in a county. And this is 2003 on the left. And each of these blue counties are counties that didn't have birthing services available in the county. And by 2018, 9 more counties were added by 2018 of counties that no longer have birthing services. Now, some of these, if you go out west out here, you have North Dakota. So you have Grand Forks and Fargo that offer those types of services right across the border. But again, you're looking at some pretty good travel distances. Again, down here where Sioux Falls is, you know, you're looking at a little bit. Where you hear it a lot, and it's kind of crazy, is up here in Grand Marais, right? And I haven't gotten an update as to whether birthing services is now offered up there. But essentially, if you were gonna go into labor, you had about a 2.5-hour ambulance ride that you had to go to give birth in Duluth. It was either that or go to Canada, which they weren't gonna allow that. Or as Lake Superior, I guess you could fly to, I don't know, Wisconsin. I don't know if you wanna do that. From what I've gathered, most of Wisconsin is drunk. So probably don't want to give birth in Wisconsin. I don't know, but it can be bad. It cannot look good here. And yeah, I think it really, once you take birthing services away, it really starts to raise concerns in a rural community. We worked with the Minnesota Hospital Association just to kind of get an idea. They helped us pick out 3 different services, and we were able to take a look at their data, or they took a look at the data to give us this chart here on how many miles had to be traveled for each of these types of services, depending on the patient's residence. And so cardiology here, you can see entirely urban areas, it takes about 20 miles on average for a patient that's in an entirely urban area to reach cardiology services. And then up here, it's nearly 75 miles on average that somebody from an entirely rural town, rural mix had to travel. Neurology, same thing, almost 100 miles for entirely rural town, rural mix. Obstetrics, whoops, sorry about that, folks. Obstetrics, again, you can see not nearly as bad as I think people maybe thought. But again, you know, if on average you have to travel 35, 40 miles to give birth, that can be a waste. But you can definitely see the gaps here that exist for different types of services. So I'm just going to end here with just a quick outline of rural frustration. Just when we were kind of doing these interviews, talking to folks, there was just general frustration about what was happening in healthcare and maybe not enough communication. And I think it kind of made hospital systems, healthcare systems look bad, when actuality, they're kind of reacting to an entire framework that's pushing them in this direction. So this well-intentioned policy framework of lowering costs, providing better services, better outcomes, it's so well-intentioned and it makes a lot of sense. And there's no reason why we wouldn't want to head in this direction, but it's kind of having these impacts of rural, smaller rural hospitals and clinics kind of being left behind because there's just no good way of them to survive in this financial world. So the one it gets talked about a lot is Albert Lee and what happened at Mayo, with Mayo taking away some of their hospital services. And we're not taking sides on either way. I think I was talking to a healthcare expert in the field, and I think he put it so well in saying everybody feels bad about how this went down. The Mayo feels bad, the community feels bad. It's just not how we want things to work out. And I think it's because we kind of have a gap right now where things aren't being communicated very well. And Albert Lee, they, tried to negotiate with Mayo, and Mayo was like, look, we're pulling out. We can't provide all these services in Albert Lee. You're just going to have to come to Austin for these services. And that was hard for Albert Lee to get over and to accept. And so they kind of organized and reached out to another healthcare provider from Iowa who is now coming in to start a clinic and hopefully start a hospital there as well, maybe a little competition with the Mayo. And so there's a lot of nuance in this, but some of the things that were missed is that just looking ahead is that one, there's a desire for local input on some of this stuff. Right now, decisions are being made and no one's getting any sort of input. One, because the healthcare providers have to act in a way that makes sense for them. They're trying to survive in a financial and policy framework that's incentivizing them to become more efficient while at the same time increasing outcomes. And that can mean consolidation of services. That's just the way this works. While at the same time, though, there's no one telling the local communities this is how things are rolling out and this is how things are operating. And so what does that look like? And so we would argue that a desire for local input is really necessary, and there needs to be more engagement between healthcare providers and community leaders. A need for assessments. Right now, we're not doing much as far as if a healthcare service does become consolidated or is eliminated from a certain area, it's consolidated to maybe a larger community or a different community. There right now is no one measuring what kind of impact does that mean on accessing those services for the region that previously had those services. And that's kind of scary to us, and that needs to change. And the third thing is there might be a little room for competition. When we look at the Albert Lee and the Mayo and with Mercy One coming in, that's a very interesting scenario in which another healthcare system was like, I think we can make this work financially. So it's not just about financial, rural areas can maybe make this work and make a little bit of competitive advantage in these types of situations. So looking ahead, I'll just end with this before I turn it over to Vizong, is that I think particularly during COVID-19, and I would say just over the past few years, we are now starting to grapple with the idea that access doesn't mean in person. It doesn't have to mean a facility that I go to. Telehealth is a prime example during COVID-19. It did tremendously well, and it's gone really well. Some of the current research that's currently coming out has really shown that outcomes in telehealth are just as good as in person, if not better. And that's really, really cool to see. There's other ideas, community paramedics, if anybody's familiar with that. I know Mark Jones, one of our panelists, this is something he's very passionate about. I think it's a really cool idea, which is getting our EMS system to be a part of filling in some of the gaps that exist in healthcare services by showing up at people's homes. So rather than trying to figure out how we provide transportation to people to reach these services, why don't we come to them and we can get EMS involved to do some of this work while at the same time maybe helping them be more financially stable. There's more talk about transportation services. If you are curious, we did release some research that looked at volunteer drivers. And that's kind of a big concern right now, is that we don't have enough volunteer drivers for people to reach healthcare services. And that's a big piece. And the fourth thing I say is we're seeing a lot more community engagement. We're seeing a lot more communities, county commissioners, city councils approach their healthcare providers and say, hey, how are you doing? How can we help? How can we work together to make this happen? How can we work together so you don't have to leave, so that you're financially safe and feasible? What role can we play? And that's a big piece of this, is that it's no longer healthcare industry and everybody else, but that we're all taking part in the health of our communities. So I got panelist Q&A, but I did want to hand it over to Vizong, who has done a lot of work around, I know, kind of metro-based, urban-based, and people of color and non-white populations and their access, kind of healthcare equity, which we didn't touch on at all in our research. And I think this conversation really requires us to have a piece of that. And so, Vizong, I'm going to hand it over to you. Feel free to share your screen and do whatever you think is necessary. And then once you're done, Christina is going to take over and roll on with the panel, okay?
Sure. Thank you, Kelly. And full disclaimer, I don't have any prepared slides. I'm going to quote a good friend of mine, John Powell, who often says, if you have power and a point, you don't need PowerPoints. And so I'm going to borrow that wisdom. Plus, I don't actually have PowerPoints with me. But thank you, Kelly. I'm responding to your presentation and trying to formulate some key and instinctual responses. As I do that, I do want to just give you all a little bit more background on who I am and where I'm coming from. So I'm Vizong Moore, and I'm the Director of Racial and Health Equity Advocacy at Blue Cross and Blue Shield of Minnesota. Blue Cross, as you may know, is the largest health plan in the state. As I absorb what Kelly is sharing, a few things stand out to me. One, that the shifts and the consolidation that he's naming is driven by these upstream political and policy drivers, really, as Kelly mentioned, well-intended and trying to lower healthcare costs. One thing that I want to just illuminate for the audience is that what we know in terms of what creates health from public health science, from epidemiology, is that only about 10% of what creates health occurs within direct healthcare. So only 10% of what creates health occur within the four walls of a physician's office. 90%, the majority of what creates health, this is what public health practitioners call the social determinants of health. Most of what creates health happens in your neighborhoods, in your community, based on transportation or lack of transportation, based on education level, your gender, and obviously the experience of racism and other structural inequities too. And so I just want to right size the challenge of where we're talking about today, that although we're talking about healthcare access, I think healthcare access belongs to a broader challenge in structural, racial, and health inequities. And I just want to make sure that as I use these terms that I unpack that a little bit. And when we're saying racial and health inequities, we're being very explicit about racial, cultural, and ethnic inequities, but also I want you to understand that it's not exclusively racial and ethnic inequities. We see a strong connection between race and gender, race and income, race and disability, race and sexual orientation. And so MDH actually has a great framework around leading with race explicitly, but not exclusively. So I want you all to understand how intersectional we do see racial and health inequities. And so the key kind of point I would want to lift up for you all is that, again, only 10% of what creates health happens within healthcare. And then if I did have a slide, I would show you that in terms of spending, what do we pay for? 90% of what we pay for in health is that 10% healthcare medical treatment. And only 10% of what we pay for is in community upstream prevention. And so you can see how those two infographics, if you will, mirror each, conversely or inversely mirror each other. And so that is another inequity in itself, in what we spend based on what are the key drivers of health. I also want to, one other goal I want to kind of address here, and I really appreciate Kate Cimino and the Center for Rural Policy and Development and all the organizers for just the framing of this conversation around interconnections and making sure that as we talk about the distinctions between rural and metro, that in my experience and in my my work, health is truly ecological. It's ecological from individual to interpersonal to organizational, community, and structural. And that certainly honors the distinction in geographic differences, but it also perhaps even more so honors the shared struggles and shared prosperity, and that health is not just something that is outsourced and externalized to an institution, and it's not something that you can just deal with personally as well. So it's neither a purely individual issue, and it's not something that is happening aloof and far away in another solar system, if you will. And so I want to really make sure we can see the interconnections in what creates health. And so I wanted to also give you a background that much of the work that I do is actually in prevention and in public health. I saw a question come up on the chat around transportation. And one of the first state laws that I worked on to pass was complete streets. which is an active and equitable transportation policy. And keep in mind, I'm at Blue Cross Blue Shield. And so why would somebody at Blue Cross Blue Shield even create a coalition or work on a transportation policy? And what we've known from public health science is that the built environment and connections and having equitable and convenient modes of transportation to and from a grocery store, to where you work, where you play, where you get your health care is health policy. Transportation policy is health policy. And so the shift that I see in my organization and in the industry is that in addition to what Kelly articulated, we're going further upstream. We're working on prevention issues because we know that the biggest drivers of healthcare costs are in preventable death and disease. And so the better we can get ahead of the curve and address challenges where they occur in community, the less we have to spend and address in the downstream treatment and healthcare access segment of the health continuum. The other point I'll lift up, and I'm not sure, Christina, you can help facilitate and make sure I'm on time here. I just want to make sure that as we talk about racial and health equity, that is really understood as both a moral imperative and a business imperative as well. It's Blue Cross, as you may know, sued the tobacco industry in the mid-90s. And so my role in my entire department is resourced, not from premiums, but from tobacco settlement dollars. And so it's with a sense of redemption that we use these dollars and resources to go upstream and work on preventable death and disease. And where we see that mostly happening is across racial and ethnic lines, both in rural and metro areas. And again, that's not exclusive. That is connecting across many different demographics and geographic lines. And so much of the work that I do is actually in food security, it's in transportation, it's in housing, it's in education policy. And where I'm most excited is to really move racial and health equity into governance. So we're beginning to examine and understand racism as a public health crisis. And once we understand that it's been a crisis from epidemics to pandemics, from diabetes to COVID-19, we've seen these inequities in prevalence, in mortality, in morbidity. And with COVID-19, we've seen the inequities in exposure, infection, death, and vaccine distributions. And so I just want to connect the dots there between the healthcare access and all the upstream social determinants of health. And so that's kind of my instinctual response, and I'll turn it over to Christina to help us segue to the next series of questions.
That's great, Bazong. Thank you so much. And that really leads well into starting our panel discussion. So if we could get Mark and Toby to bring up their video, that would be awesome. We have about half an hour, which is perfect to have our panel discussion. And there's a lot of questions coming in already through the chat, so I'll make sure to integrate those because I always think it makes it more interactive and fun. So kind of let's start where Bazong left off there, which is, access to quality healthcare is very different depending on, where you live, your socioeconomic background, quite frankly, the color of your skin. What have we learned from the pandemic to make positive fundamental changes to improve people's access to good care? Toby, if you want to just start that off, to really quick bio and kind of answer that first question, that would be great.
Sure. Thank you, Christina, and thanks for having me here. Great to be with you. Just briefly, president for New Ulm Medical Center in New Ulm, Minnesota. I've been here for 15 years. New Ulm Medical Center has been part of Allina Health for the past 40 years. I just have a deep passion for rural communities, rural health, born and raised in rural North Dakota, and then rural Wisconsin for 4, and now 15 years in New Ulm. And I guess kind of related to your question of what has changed or what have we learned through the pandemic, I think it was just mentioned a little bit earlier, the disparities and the lack of equity has been around for decades. I would say it's probably more pronounced now for many reasons as we have kind of navigated our way through the last 15 months of dealing with COVID. this is a complex issue, but it has been mentioned, reasonable expectations of what clinical care will do for health equity and health outcome improvement of knowing health is created at the community level. I would say one issue is just the affordability of healthcare. And I think we're seeing that now, and we saw it with previous to COVID and management of chronic diseases are responding. People don't have good health insurance. It's really hard for them to access the healthcare system. And especially in rural communities, as Kelly had mentioned earlier, generally higher uninsured and poorer. And when we look at health rankings across the country, it's overwhelmingly rural counties are the ones that have the lowest health factors and the worst health outcomes across our communities. The one thing I would share though is our healthcare systems, I think, through a matter of more collaboration across the community, of which we have achieved, I think have an opportunity to bring a greater affordability. And we've shared, if our healthcare solutions are not affordable, then they're not solutions for the people we're here to serve. And it's pretty hard, I think, if you look at the cost of healthcare to say too many pieces or parts of it are affordable today. So we have to do more, I think, in that area to help, but I'll let some of the other panelists chime in here as well of kind of their experience through the pandemic and the introductions.
Yeah, Mark, go ahead.
Thank you. Mark Jones, Executive Director of the Minnesota Rural Health Association. We're a member-based advocacy organization, and we work real hard to be the voice of rural health. I've been in healthcare for about 30 years. I am a retired paramedic, so I hope to be able to speak to that. Toby brought up a great point about collaboration. And I think coming out of the pandemic, I think that's in rural Minnesota. I think that was one of our bright points, was that those communities that were very connected, all their systems were connected between the hospitals, the clinics, the social service, human service systems, emergency management, public health, where they all worked together and they were able to identify those people that were at the highest risk. They were able to reach out to them, connect with them, to keep them healthy, to get to them, to get the vaccine to them. If we look at the counties in Minnesota and rural Minnesota that have high vaccination rates, they're the most tight-knit counties where their public health systems are best connected to the people. So I think that's one thing that we can build on going forward.
Yeah, that's great. Bazan, do you want to just talk about, from your perspective, what access to healthcare means to you, depending on where you live, what you look like, how you're able to communicate to your provider?
Yeah, I feel like I may be belaboring some of my points that I mentioned earlier, and so I'm happy to just move on. Well, okay, I lied a little bit. Maybe the one thing I would take away from COVID-19 is that it really illuminated the inadequacies and inequities in our public health infrastructure. It showed how aloof and siloed our public health response, how connected public health is to, ironically, health care, and to our schools, to our workforce, and that it was really set up for just to be slow and fairly bureaucratic. And so I think there's a lesson learned is to integrate public health early, often, and authentically with communities, and emphasize the public aspect of public health.
Yeah. So,
Christine, I do believe that is, if I could follow up on that, because I appreciate that that was brought up, and Mark highlighted. I think that's where rural can lead. In our region here, we've been working over the last 10 years of building a community kind of collaborative initiative called the Heart of New Ulm, and expanding across the county, bringing together public health, school systems, city, government, county, chamber, all to create health as a shared goal by all, and to make sure our kind of strategies across education, city, county, commerce, all kind of focused, even complete streets resolutions, all focused on how do we realize full health potential for all across our area, and recognizing the medical care is going to be a small slice of that. And we have been working on that for 10 years and have had the public health director on our community hospital board to kind of work on the relationship of how do we collaborate more, how do we do more together, recognizing there's going to be less resource available in our rural communities to focus on big initiatives. Obviously, we didn't know COVID was going to be in our future, but I think it did help many of our rural communities to have some of those relationships already in place. And I can speak at least directly for it was extremely beneficial for our response and even today related to the pandemic.
Yeah. What are the consequences of access barriers in rural areas? Mark, do you want to take that one?
Well, I think it comes down to people foregoing care. When they forego care, then their health issues compound. And we deal with a complete illness-based healthcare system where, as Vajang pointed out, a wellness-based system is much less expensive. It keeps the community happier. It keeps the community stronger. So I think the access issue is we just end up with the poor care. And there's so many pieces that go into why people don't access the pandemic. We shut everything down, not everything, but and I'm fearful that there are people who have yet to come back and take care of their health care and may not.
Toby, any thoughts on that?
Yeah, there's appreciate. Unfortunately, the outcomes are not what we'd want, but this has been pretty well researched, and we can see across the country when people don't have access to high quality care, and it's beyond an EMS system or beyond a primary care provider in their area or in their county. We are seeing just tragic outcomes. So there's a 23% higher mortality rate in rural areas when our Medicare population doesn't have access to specialists, about a 40% higher hospitalization rate. So obviously leading to more complications, shorter life expectancy, costs go up. And really it is then starts to cause an out-migration and losing access to healthcare. So specifically in southwestern Minnesota, one could look across southwestern Minnesota and see hospitals and access to hospitals, but we serve a region that's about 100 miles by 100 miles where there's not a single specialist outside of New Ulm. So we have about 70 providers across 20 specialties for this region. And outside of New Ulm, as you go west or south or north in great distances, there's no OBGYNs, there's no oncologists, there's no cardiologists, there's no pulmonologist. And thankfully, through the pandemic, I think we have figured out how to transform what access can look like. We just achieved over 11,000 virtual visits since the beginning of the pandemic across 20 different specialties for the 30,000 residents we're serving in this area. So I think the pandemic has, I think, caused the healthcare system to be more nimble, to kind of act from a standpoint of incident command, to say we need solutions, not in 3 years from now, but maybe in 3 weeks, 3 months. So there's a sense of urgency of how do we unlock and remove some of these barriers. Transportation, many others are kind of stacked against rural populations.
Yeah. We know that racial inequity in healthcare is literally costing lives. Some numbers from Blue Cross Blue Shield found that if we improve access to care, we could save at least 766 lives each year and more than $2 billion. Those numbers are startling. Zong, do you want to just kind of talk more about that and just some of the steps that your organization is doing to correct that?
Yeah, thank you for bringing that up, Christina. And I just want to be very clear that this isn't a bypass of the moral imperative to address racial and health inequities, but the cost of these health inequities study that you referenced was in partnership with the School of School of Medicine at the U of M and also with the Humphrey School of Public Affairs. And so we quantified the cost of these differences in health across communities. And what it brought up was that it costs Minnesota, just the state alone, on an annual basis, $2.26 billion. And that's not even direct medical costs. That's just lost labor, lost employment, lost wages. And so those are really kind of the social economic costs. And so I just want to be very clear that when we see these health inequities defined by CDC and WHO as differences in health that are avoidable, preventable, and unjust. That's the formal definition of health inequity. And so when your initial question, I just want to be clear that it costs us lives, it costs our economy in productivity, and it costs us in our premiums and our taxes. And so there's a common good benefit and a common cost. And too often, I think racial and health inequities gets framed as a marginal issue for marginalized communities. And we need to recognize that actually there's no free lunch here. And that is actually hurting all of us, whether we detect it or not. So I think that study really just helps make an airtight case that doing this is not only the right thing to do, it's effective. And if we're not adaptive in addressing this, we're all going to suffer for that.
Yeah, that's a great point, Bazong. You know, kind of expanding on that, for the first time in Minnesota's history, the legislature formed a committee dedicated to racial justice. How do we get across this idea to greater Minnesota that, you know, racism is a public health crisis too? I don't know if Mark or Toby wants to take a shot at that.
I think at least in this region and specifically our system, you know, Kelly had brought up what's success look like for healthcare providers and healthcare systems, and the triple aim framework has been around for probably a decade or 2 decades. And what I share is, you know, could we find evidence, be found guilty that we're pursuing the triple aim for all, and so that in a rural community you can realize your health potential and be in New Ulm or Pelican Rapids or whatever rural community across Minnesota. It's not a choice of you got to, you know, live outside of a rural area. So, you know, specifically, you know, we look at our quality of care, access to care through, and we have data analytics to help support what is the gap, what is the disparity, and then what are our strategies to close that. So we can see for colon cancer screening, there's been a significant difference in colon cancer screening rates and other prevention measures. We started about 8 or 9 years ago measuring here in the New Ulm community, and put together initiatives around that to close that gap and have had success. I would tell you, it's not in the same way of traditional kind of medical care. Very little of this is going to be achieved through a 15-minute clinic appointment. Most of this is going to be happening at the community level, the collaborative partnerships, and adding some non-medical staff, care coordinators, social workers to understand what the barriers are. About 7 or 8 years ago, we added a social worker to our small ER and partnered with an organization called South Country Health Alliance, which is a Medicaid managed care payer in southern Minnesota and other rural counties across the state. What we found in 1 year is we reduced costs by $750,000 and about 40% less ER visits and admissions, and mostly for the low income population that was covered by South Country Health Alliance. And the strategy was connecting them to community resources, mental health resources, and other conditions that they were struggling with that led to greater utilization of the healthcare. So it got to higher value. And what I was really proud of is we did pre and post surveys for this population of how did they feel about their health before engaging with this program and after. And so we can look at costs, we can look at screenings. For the majority of the population, it was night and day after engaging with a care coordinator to understand their life's challenges and what priorities they had of understanding kind of that in a shared decision-making model. So I think if we're accountable to the outcomes, we're transparent with our data of what does health look like for all of the members of our community and where are we at on our path of achieving that, I think it takes us a long way in that accountability.
Yeah. Well, let's discuss costs. There's been mergers, clinics consolidating, layoffs, obviously, you know, a lot of that exacerbated by the pandemic. Have those moves impacted healthcare access in greater and in urban areas of the state? Mark, what do you think about just the mergers and the layoffs, especially in the, you know, parts of town that you're familiar with?
Well, I think the mergers and the acquisitions and even the collaborations, the partnerships that have been built across healthcare. I think they've in general been positive. I think you can look at Toby's organization and everyone that they've brought in together to work for their community and for the health of their community. I think that as we move forward, we're going to see more of it. I hope that we see more of it. I hope that it moves further across the through the healthcare spectrum to bring in more mental health, substance use disorder, oral health, because we know that all of those areas of healthcare are interconnected. So we never want to see access lost. We never want to see a hospital close or a clinic close or a dental office close or an optometrist leave town. But sometimes it's just going to happen. It's then that the community needs to work together to support itself and to find alternatives, to rally together, to take people to where they need to be, and then bring those alternate services in, whether it's through telehealth, whether it's through community-based services. So the layoffs, I think that's a whole nother topic. That's a workforce topic. And I think Toby would agree that not only the layoffs, but the retirements we're going to be looking at are going to threaten rural healthcare also.
Fazong, what's just your viewpoint on, mergers and consolidations in the metro area? How does that impact access and quality of healthcare?
In the metro area, I'm not sure if it's having as much of an impact as it is in rural areas because of proximity. I don't want to minimize that, but my sense is that it's not impact. We're not driving 50 miles to a provider. But again, I would just emphasize the correlation between inequities in direct healthcare access and food security and access to transportation. And if you were to look at a map of the Twin Cities metro area, you can look at zip codes and see up to 6 years of difference in lifespan from Minneapolis to Eagan. You can see these differences. And what I would invite us all, if we, I guess this is just an exercise in visualization since I don't have PowerPoint, is that if you were to map out where all the grocery stores are, if you were to map out where all the parks are, the trail, walking and biking system, and you will see a strong overlay between where there are gaps in the physical and social health system and where the lifespans are the shortest as well. And so I would just draw on that connection there.
Yeah, it's a powerful visualization. Let's just take a question from one of our participants here. Lisa Cran, I think I'm pronouncing that correctly, says, rather than consolidation, think bigger. Dealing with one single payer Medicare would mean drastically fewer hours of uncompensated administrative time, fewer office staff, and lower overhead. Medicare for All would simplify hospital payments by funding them through global budgets, similar to the way fire departments are paid, rather than the current patient-by-patient payments, saving billions more in administrative costs. Anyone have a reaction or response to that comment?
For at least in rural hospitals, clinics, and others, funding has been a great challenge. Minnesota, so kind of depending on single payer system we have today, it doesn't appear too many have a promising outlook for the smallest providers that are out there or systems. The Minnesota Hospital Association just released a report pre-pandemic 2019, 41% of Minnesota's rural hospitals lost money in 2019 on hospital operations. And that picture I think is going to get even more challenging coming out of the pandemic. So I think for those that would like to just maintain what we have, I don't think our outcomes are anything we're overly proud of in terms of health and in terms of affordability. So I see change change is absolutely appropriate from the healthcare system, as well as from a policy standpoint of, and I think there's going to be good ideas when more voices are heard here. I think, collaboration is going to be one that I see as essential for rural communities. Over the last 50 years, most communities had focused on, they had their own school system, they had their own hospital, they had kind of everything pretty much at every 10 or 15 mile stop. And we're seeing, education had to do a lot of consolidation and collaboration. And I think with some kind of more positive intent on the front end of how do we strengthen the healthcare system, I'm a believer, and I've experienced it, at least in our region, we can get stronger together rather than see ourselves as competitors, either from a provider to another provider or a provider to a payer of how can we do more together, and together we get stronger for the people we're here to serve, and understand how healthcare has changed since 50 years ago when most hospitals were built. We're not going to define the future of healthcare by how many inpatient beds we have, but what are the services that rural populations really need? How do they access them? And what's face-to-face care, what's virtual care, and all of those issues I think can hopefully solve together and more affordably for our rural populations.
We've kind of touched on, transportation is key both in rural and urban areas. Let's also pivot to community paramedicine. I mean, if you don't have enough paramedics to take you to a hospital if you're having an emergency, that's a massive problem. Mark, this is something you're very passionate about. Would you like to just, talk more about this issue?
Yeah, so in 2011, Minnesota enacted the community paramedicine laws. And looking back to what our intention was, we sort of sold it as a rule savior. So this was going to be the way that we got care to people, so people didn't have to go to the hospital or the clinic, as the outlook for hospitals and clinics at that time wasn't the greatest. Turns out, after we get the laws enacted and we start training people, we find out that it's going to be very difficult for a rural community to implement it. Take into consideration that only 25% of our rural communities even staff with paramedics on their ambulance. So that's 75% of our communities that have EMTs that we would then have to train to paramedic, or we'd have these huge holes. So once again, the larger communities, if they had paramedics and they trained community paramedic and they implemented the community-based program of community paramedicine, they'd be winners, and we'd still have 75% of our rural communities would be losers. So we really lost, we lost out on maybe what we really wanted to do. Now, in the metropolitan areas where they're implementing community paramedics, they're very successful, and they're starting to show very easily the savings. So moving forward, community-based medicine and community paramedics, I think, in rural communities is critical. However, CMS doesn't pay for it. There is only certain commercial health plans pay for it. And in Minnesota, we have a Medicaid payment for it, but it doesn't include travel and it doesn't include mileage. So travel time and mileage. So for a $15 visit to travel out 25 miles to see a patient, it just doesn't pay. And if we look at 5% of our population consumes half of the healthcare, that's a very targeted group, a very small group that the community paramedics can help take care of in their homes where they live. When you go into someone's home, you really learn how they live. They become very comfortable with you. They share a lot. Our home care friends can attribute to this. I don't know how many homes I went into as a paramedic where it was a diabetic patient and we opened up the fridge and there was no food in the fridge, to find out that they don't have the money, that they lost their job or they couldn't get to work, that they don't have any money to buy food. They can't even get to the grocery store because the grocery store is 3 towns away. So that community-based care and the community paramedicine, I think, is really one of the areas we need to build on. Team those up with community health workers so we can collaboratively start addressing those social determinants, working with primary care to coordinate everything together. I think that's one way to decrease the cost of healthcare, and to just even the playing field.
Yeah. So where do we go from here? How do we start making people feel more comfortable seeking care, talking to their doctor, finding out the right, specialty expertise to go to, access to better food? I know that's a lot thrown at everyone, but what are some of just the next steps, to start heading in the right direction following, this pandemic, a racial reckoning, following the murder of George Floyd? There's been so much happening here in our state. Where do we go from here to try to, make some more positive change?
Yes, maybe I'll start, and I think some of it's been acknowledged, so I'll recap. One is a focus on what whole person care and health looks like for individuals, families, and overall our communities. And then how do we make sure our payment system aligns to pay for, invest in, and reward when we're focused on health improvement, well-being, and understanding some of that is not going to have a return in the next 12-month cycle of an insurance contract, but our investments like complete streets and other investments in a community that have generational type of benefits. It's important for us to understand kind of how we're going to measure success in the future. So I would say first, recognizing the importance of all of the factors that lead to better health for populations. And then we have a very rich, I would say, system with lots of health information and data. I think some transparency of understanding, here's where we're at, and kind of acknowledging, and then kind of building plans and collaboration to figure out how do we improve in closing some of the disparity gaps that we're having. But I would say most, Mark just mentioned, most people would not understand that 75% of Minnesota does not have access to a paramedic showing up if they dial 911. I don't think most of Minnesota knows a quarter of the counties you cannot have a baby in and go to a hospital and expect to have a baby. I mean, that there is a level of awareness and understanding of the health challenges that are currently kind of facing our state, our country, of understanding what they truly are, where we're at in outcomes, and then being more focused on, like I had shared, probably collaboration would be my kind of key word for today, that I'm hopeful coming out of the pandemic, we're going to see more of in rural communities, as well as urban partners across payers, across communities, across providers.
I'd agree with Toby on the collaboration and the investments into the community, and not just money for healthcare, but really investing into the communities and making sure that everyone has access to a good job, a good home, a good education, that there's childcare available, that there's access to food, and there's access to transportation. So really looking at it and looking at it for everyone having access to it, not only the larger rural communities, and not only those communities that may have a craftful grant writer, but really making sure that from all four corners of the state and everything in between, every community has the same ability to have that access to making our people's lives healthier.
Fazan?
I know we're short on time, so I'll test my brevity here. I think there's no silver bullet, but the key theme I'm hearing from Toby and Mark and from Kelly is the centering of community engagement and the upfront consideration of racial and health equity impacts, whether that's applied to COVID or food security or transportation. We've treated equity as an amenity and not as an essential criterion in how we assess policies, budgeting, infrastructure. And so we want to make sure that it is, we're taking a prevention-oriented decision-making process and embedding that, whether we're trying to craft a new bill or a new staff or a new budget. And I think that is the essential pattern we want to do, is to make sure it's built up front and deeply into how we make decisions.
Great. Well, we're going to end it there. Thank you so much to all the panelists and Kelly for presenting. I thought it was a great discussion. A lot of work still needs to be done. Thank you again for allowing me to moderate all of these different conversations we've had with this interconnected series. And I hope everyone enjoys the rest of their day. Thanks all.
Thank you, everyone. Thanks.